Now let's shift gears and focus on managing patients with polycythemia vera that are facing challenges with their traditional treatments. So let's again begin with a case. Margaret is a 63-year-old female who has polycythemia vera, JAK2 mutated, diagnosed 5 years ago. 2 weeks ago, she went into the emergency department with angina, was admitted to critical care, and she did have a myocardial infarction. This was her first known thrombotic event since she was diagnosed. Now, she goes to her hematologist, and she's describing ongoing symptoms of fatigue, headache, abdominal discomfort, and is found to have an enlarged spleen. Her laboratory values show that she has thrombocytosis, some residual erythrocytosis, despite the phlebotomies in the hospital. Prior to her myocardial infarction, her hydroxyurea was 1.5 grams a day at her maximum tolerated dose. She was on low-dose aspirin, and she was still requiring phlebotomies 2 to 3 times a year. So what should we recommend next for Margaret? Well, Margaret really has had resistance to her therapy with hydroxyurea, namely using the current criteria by the European Leukemia Net. We can divide patients who are having a suboptimal response to hydroxyurea into those that face issues of resistance, meaning residual erythrocytosis, leukocytosis, thrombocytosis, splenomegaly, or symptoms really after an adequate trial of Hydrea more than 3 months at a maximum tolerated dose. Alternatively, patients can be intolerant, having excessive cytopenias, leg ulcers, GI toxicities, fevers, cutaneous manifestations, or recurrent skin cancers. In my practice, I would say that final one is a common one. I see patients on Hydrea, particularly in my practice in Arizona, that have multiple basal cell carcinomas, actinic keratoses, and it's not a good fit. Now, my group published a couple years back in the Journal of Clinical Oncology that individuals that have quote-unquote failed hydroxyurea can be quite symptomatic, whether they have failed it on the basis of resistance, intolerance, and or the presence of splenomegaly. Colleagues in Spain did an analysis that found that patients with polycythemia vera who met these criteria of Hydrea resistance or intolerance had a more difficult disease. They had a 5.6 increased risk of death, fold increased risk of progression to acute leukemia or primary myelofibrosis. So these are not your standard patients. They have much more difficult disease. In the past, we had limited options for these individuals with inadequately controlled P-Vera on hydroxyurea. We could use interferon, although there can be difficulties with flu-like symptoms, fatigue, neuropsychiatric symptoms, or autoimmune disorders. There's other chemotherapy drugs we could use, such as busulfan. However, it can be quite myelosuppressive and sometimes not well tolerated or toxic to the lungs. Radioactive phosphorus, which clearly is leukemogenic, and we tend to utilize really only in very elderly patients. And anagrelide, which can control thrombocytosis, but does not control erythrocytosis and is really not a great option. In that sort of setting were the trials developed for ruxolitinib in polycythemia vera. As a JAK inhibitor, it had long been speculated that JAK inhibition would be effective for patients with polycythemia vera. A phase 2 study had demonstrated that it was active and safe in patients that had failed hydroxyurea. Therefore, there was a trial done, a randomized study of ruxolitinib versus best alternative therapy, with a goal of trying to improve the course for patients with polycythemia vera that had failed hydroxyurea. It was demonstrated that ruxolitinib was superior to best alternative therapy for control of hematocrit, reduction of splenomegaly, reduction in PV-related symptoms, and a trend toward fewer thrombotic events. At baseline, both groups of patients, a little over 100 patients in each arm, had relatively similar disease features. At the endpoints at week 32, it showed unequivocally that ruxolitinib was vastly superior for control of the primary endpoint, which included reduction in splenomegaly, over a 35% reduction in volume, and better control of the hematocrit. Additionally, it was shown that ruxolitinib was very superior for improvement in disease-associated symptoms, both the symptoms in aggregate or broken down by symptoms associated with elevated cytokines, such as tiredness, pruritus, night sweats, symptoms associated with hyperviscosity, such as headaches, difficulties with concentration and dizziness, and symptoms associated with the spleen, fullness, abdominal discomfort, etc. It has been demonstrated and reported that the responses can be durable, as well as improvements in blood counts seen over time. And data now extending to 80 weeks with patients with ruxolitinib on this trial showed good control of leukocytosis and thrombocytosis in individuals on ruxolitinib. Now, over time, as we look at the laboratory values, the rate of grade 3 or 4 thrombocytopenia or anemia is very low. This challenge, which can be present more in patients with myelofibrosis, is clearly less so in those with polycythemia vera, given the more intrinsic nature of elevated counts in this group. As we look at a rate of thromboembolic events, the trial was not powered with that as an endpoint. Regardless, a strong trend toward fewer events have been seen with those patients with polycythemia vera treated with ruxolitinib. It is felt in part due to cytoreduction, but it also may be due to improvement in inflammatory cytokines in the blood in the patient that may be associated with increased risk of thrombosis. As we look at toxicities over time, non-hematologic adverse events are at a low rate and show that the drug is quite well tolerated. As we look at longer-term events, the main things I advise patients and caution colleagues when discussing ruxolitinib in this setting is, one, to be aware that there does seem to be a slight increased risk of herpes zoster, and that, second, there may be a slightly increased risk of non-melanomatous skin cancers. This part is a little difficult to differentiate from the patient's prior history, and that all patients had been previously exposed to hydroxyurea and were resistant or intolerant to hydroxyurea, and on that basis, likely at a much higher rate of risk of skin cancers as a baseline. I'd conclude by saying that patients can become resistant or intolerant to hydroxyurea, frequently leading to inadequate disease control, and it's been demonstrated that these patients have a worse natural history unless if we do something different. Until recently, options for such patients were quite limited. Based on the efficacy results from the randomized clinical trials, ruxolitinib is now FDA approved and available for managing patients with polycythemia vera. And its utilization should be based on an assessment of the individual patient's needs and discussion of the risk and benefits, with particular awareness regarding symptom burden, splenomegaly, and the need to control elevated blood counts.